panelists introduce ourselves, I'm really hopeful that they have a couple of good questions to bring to the table. So Mary or Melinda, do you want to jump in and just very quickly say hello and hit us with your discussion points?
Sure. Hi, this is Mary Ann Fisanick. Thank you so much. I'm honored to be on this panel with such experts. Thank you. I just had a few things I wanted to just add on to the wonderful presentation. Sometimes we do forget, as you had brought up about, you didn't always think about acidosis, and there are some odd diagnoses that we may not always capture and not always think that it impacts upon, especially the quality scores. So what I've noticed from like a Vizient variable type perspective is that, oddly enough, your hypo and hyperkalemias, which a lot of times in the past I would have just ignored or poo-pooed, but those do have significance in mortality scores, especially around some of your brain surgeries and things like that. And that was shocking to me. That was just a very odd type of finding. And along the same vein, some of the other diagnoses when I review, when I'm looking to increase that SOI and ROM in the 3M system. So I would have never dreamed it, but subluxation. So if you have a subluxation at one point, say in your spine, versus another area that might have been operated or might have been the cause of the admission, that subluxation, if documented and monitored with x-rays, et cetera, will also increase your severity of illness and risk of mortality, as will hypotension, your electrolytes either being increased or decreased, and alkalosis and acidosis. So those are the things that I just wanted to comment on very briefly. So thank you very much for allowing me to join.
Yes, this is Melinda Smaller. And again, I do appreciate the material that you put together. It's very insightful. One that I thought was very important was the information regarding the eye diagnosis that can impact the ROM and SOI based on like a patient with stroke. A lot of times we don't bring on the diagnosis listed normally in the past medical history, such as glaucoma, for certain patients with stroke, because it's not something that we would take on that's still being impacting the care. So just interesting to hear that and look at it a lot further than just what we're seeing in the final impressions. So there's a lot of key points that you've covered today that really hits it home, and know that we have a lot of education, re-education opportunities to make sure that we're all in sync with making sure we're hitting that bar to get to a point where Mayo is.
Yeah, that's a great point. And let's also open it up. I don't know if Chris may have some questions from the audience that have come through that I haven't been able to sort of keep track of, that the whole panel maybe could have some consideration for. Do we have any?
Yeah, no, absolutely. Thank you again for the presentation, and obviously not only to you, Alan, Amy, but also Mary and Melinda. And this to me is the fun part. This is where we get to just have natural, open discussion. And I think updates in coding guidelines and clinics, and just the impacts that those can have. And I just wanted to see if maybe you can kind of touch on that subject that we were discussing yesterday, and kind of how that would kind of correlate to the audience here.
Sure, absolutely. So one of the things that I think sometimes when we have those annual coding updates that come out in October, through no fault of their own, I think sometimes the cooperating parties sort of bury the lead. And what I mean by that is all of the focus is on the new codes, the deleted codes, changes to the guidelines. GCS scores, anyone? You know, that was the big topic of discussion. And I think sometimes what may get overlooked are those subtle changes to the tabular instructional notes, particularly when an excludes 1 becomes an excludes 2. So one of the things we saw in October was previously cardiogenic shock and cardiac arrest had an excludes 1. And what made it even more confusing is that in September, late September of 2020, there was a coding clinic that reinforced that they were not to be coded together due to the excludes 1, but it alluded to the fact that that was something they were looking at changing. Well, there was no big grand announcement or fanfare, but that did in fact change. So we, you know, put in great efforts at the organizations that I worked with to make sure that the CDI specialists, the coders, and all of the physicians understood, because on a lot of our mortalities, we wouldn't necessarily query for that cardiogenic shock per se, because if the patient had a cardiac arrest that was going to be reported or vice versa, we knew they couldn't be reported together. So just kind of a heads up to the audience that, you know, that's not the only time. In recent years, there have been sort of shifts in the general practice or historical practice of what we could and could not code together. So it's extremely important to pay attention and look out for those sort of pitfalls where something we think we're doing, and we can reference a very recent coding clinic, that the instructional notes themselves may have changed and now supersede that advice.
You know, ultimately, you know, really get to highlight some of those other areas, you know, to kind of extend topics of conversation. I think, Alan, as well, kind of question for you, and then also to, you know, to follow up from a Marianne and Melinda perspective, critical thinking aspect still is very much in play, and kind of, at least from a question standpoint, you know, based off of, you know, those that pass through that seem like you're doing everything well within, you know, the 3M metric, if you will, would there be any areas you would suggest to the audience, you know, are going to be at that risk of 4 already, you know, that you feel would be worth a quick look and to get a flashpoint and understanding as far as some of the methodologies you talked about today, Alan?
Yeah, so one of the things you can do if you have access to your publicly available information, and each hospital can do this, or you probably have a quality contact, and this is where like that statement gets made of, well, we don't really regularly talk to our quality people, I wouldn't even know who to ask. I would say fix that. You should know each other by name, and in a perfect world anyway, and see where your particular hospital's ranking. So, you know, one hospital may be ranking low in mortality, and with the publicly available data, a lot of times you can dig down and you can say, well, our lowest hanging fruit, for example, is mortality, and it's pneumonia, and we've been struggling there for 3 years. So without even getting into your issue about the technology right away, I know that I need to go and specifically try to figure out what is going on with my high-risk sort of pneumonia populations. What diagnoses are we missing? And you can use the CMS methodology for that. And or what sort of provider behavior could be causing that. And sometimes you will find out that there's something interesting going on that makes perfect sense. And the example that I think we had a private conversation that, you know, you may have a particular pulmonologist who's doing some new research type of work, and he's taking these really high risk patients that everybody else is wanting to put in the hospice, and he's doing stuff, and then now your mortality's high. And so as long as you can explain that, you may not like the fact that it's hitting a score somewhere, but you know what, as long as you can explain that population, that's okay. But you may find out, for example, you have a group of physicians who is just calling everything unspecified pneumonia, even though it's clearly gram-negative. Of course, that's an MCC question, but they're completely missing whatever those risk variable diagnoses are, or readmission variable things, the vascular, the heart, the lung, the diabetes, the endocrine, those things, we're missing them. We're not going back and picking them up because a lot of the patients already have CCs and MCCs. You got to do that whole root cause, and it's multiple steps, and it's going to look different at every facility. And what you may find is that your mortality scores look pretty good, but you have a 30-day readmission problem. So now you got to go to that data set within CMS, look at those risk adjustment variables, look at what you're doing with your populations there and why they seem to be coming back. It's going to be a little bit outside of the realm of just being, quote unquote, a coder or just being a CDI. You have to be a little bit of a health expert, a little bit of a public health expert, you have to understand a little bit about what your population's going on, a little bit about the documentation patterns. Maybe you have to understand your denials. Maybe something with your denials has generated some issue with people not picking things up. So that's the really high level. Now, on a specific level, you're in your encoder, whether it's Optum or 3M or whatever it is, and you're walking it through, and Amy hit on this, and you keep finding something that, or maybe you're doing audits, and you keep finding something that's missed, or the way you're selecting the tree is not quite right. It keeps misleading. It's a recurring pattern. You need to work to identify those, and then of course do education, whether that is an issue with your providers, something they're writing that's weird, or your coders and CDIs as they index it and think it's okay when it's not. So I don't want to get too much into specifics. I mean, we could drill down to a specific diagnosis, like a neurological, like a stroke or a carotid stenosis or something, and we could probably do another hour. Amy and I can talk all day. But at a high level, I think it's going to look a little different at every facility. It's time for
Right, and
CDIs
that
to get access to those quality metrics. I'm sorry, go ahead.
No, and that brings up a good point, and we've definitely been seeing this from an industry trend perspective. Stroke anymore, so really being able to identify, your challenges specifically as a facility, which may revolve around the same diagnosis as another facility, but your challenges aren't the same, and really understanding, why those items are, showing themselves as a challenge and a problem from conversation piece. And continuing on that, Marianne, from your perspective, just from a CDI education standpoint, I mean, based off of the presentation, are there any areas that kind of you from a takeaway perspective?
Yes. I think I agree with Ellen and Amy fully that we're going to try to have that severity, valence, and risk of mortality reach the 4/4, but then also do the deeper dive into the record. Are there any other diagnoses that would help from the quality perspective? So again, I think we were all sort of amazed or shocked at the diagnosis of glaucoma and the impact with cerebral vascular patients, stroke patients. And I think that you'll find that in any cohort of patients, the sort of odder type diagnoses that will increase your quality scores within each cohort. So I think it's excellent advice that Ellen and Amy both gave about doing more research about your statistics within your facility and finding how you can improve your scores, whether they're Premier, Vizient, et cetera, and raising up the quality. I think that's the major push. Before we used to worry about capturing our CCs and MCCs, and then increasing the severity of illness and risk of mortality. And I think as we delve further, we have to look at our quality scores. And if you're in a multi-system hospital, for example, a very good example was brought out. One facility may be doing very well with the pneumonias or the congestive heart failures, and others may be falling down. And just have the two facilities speak and query for those specific diagnoses, those odd diagnoses, as I call them. So
definitely, especially understanding the criteria for the different like Premier and Vizient, just making sure that we're not just coding for the death patients, but also coding for those that are still alive that can impact the later score within the 30 days time. So yeah, there's definitely a lot of takeaway and a lot of information that definitely needs to be dissipated down to the coders so that they're aware of what I may be aware of, but they may not be, because they're not necessarily coding for different criterias. They're coding of course based on the guidelines, but there are other factors, as Amy brought out, that we are not fully restricted from just coding and the final impressions on discharge summaries, but we can also code from the ED note, which ties into the inpatient care as well.
Yeah, no, that's fantastic. And then, you know, Amy, for you specifically, one of the questions from audience members stated they have a ton of denials around, and I apologize if I don't emphasize this right, hyponatremia, obesity, etc. Any sort of insight on that?
For hyponatremia denials, I see a lot of those as well. I think some of them are, when it's a clinical validation denial, obviously reach out to your physician advisor or even the attending physician. You know, I see a lot where they're trying to say it was a clinically insignificant laboratory abnormality and it shouldn't have been coded. The diagnosis of hyponatremia, for example, that's a clinical diagnosis that only a medical professional can make. So it's not the coder assuming anything incorrect. I try to use the fact a lot of times they're saying that it's not treatable unless it's 130 or lower, and that if it's 131, 132, it's not clinically significant. And so I really try to look at the patient, try to look at the clinical risk factors, and try to look at sort of, I argue the criteria a lot of times rather than the case. So I always include that they meet the definition of the term hyponatremia. A lot of times electrolyte imbalances are extremely important in the elderly. There's some good literature on there as far as asymptomatic hyponatremia. I think the other thing is that a lot of times they're applying criteria that would be used for acute symptomatic life-threatening hyponatremia. And a lot of the patients that I'm seeing, it's a chronic problem. So they're treating with sodium tablets, which is in fact a approved, widely accepted treatment protocol for chronic hyponatremia. So I think it depends on the case. But for things like that with the obesity, I typically will, again, provide all of the evidence of how clinically significant obesity is to the outcome. And then I also will throw in the coding clinic, even though it's a clinical validation denial, that essentially reiterates that from the cooperating parties perspective, obesity is always clinically significant. So it's really just about building that case and that argument. And if you're not already doing it, if you really comprehensively defend something and you're successful and you're pulling in that literature, start a template library so that as you start to get those same denials for those same reasons, you're not having to recreate the wheel every time. And you can, operationalize it and work more efficiently if you've got that go-to library with all of your clinical references.
No, awesome. Thank you so much. Like I said, that was definitely a very warranted question for sure. Alan, do you have anything to add on that topic?
Just I guess maybe some last words, which is that in general, whenever you're adding additional risk-adjusted diagnoses, you're also improving your RAF score if you're a Medicare Advantage, because they all operate on the ACC methodology for CMS Medicare incentive payments, as well as the RAF. There's overlap. And some of those might be or CCs or whatever too. So it's kind of a win-win-win that you're adding all of that. And that works for HRRP and it works for mortality. But remember, for complications, it's an inverse relationship. It's not a direct relationship. So if you're adding something that may be a CC or an HCC, and you're increasing your payment on a per case basis, that's a complication. Well, then every time you do that, we didn't talk about all the metrics, right? In the complication category, PSIs and hospital acquired conditions, you're going to be making your score worse. And that category in particular, I think, causes some of the physician leaderships to react negatively to us whenever we want to talk to them, and or specifically when we want to talk about quality. So I think we would do well to remember there's kind of an inverse relationship with what we do and complication quality, but they do align nicely when it comes to mortality and HRRP.
Nice, perfect. Amy, any kind of just a wrap up? I know we want to, be cognizant of everybody's time and, definitely like get in, as much as we can. But Amy, anything from your side, from a final words of wisdom?
No, unlike Alan, I don't always have to have the last word. And he knows I'm joking. No, I just want to thank everybody for their time today. And, if you were stimulated by the conversation today or thought there were some good takeaways, I would encourage you to, listen to some of our historic episodes or previous episodes of the podcast. We really get into these scenarios at a very deep level, philosophically, and from multiple different directions and approaches. So thank you all for your time. I really appreciate it.